Good afternoon, everyone, and thank you for joining us today. My name is Carmen Restenbeck. I'm the CEO and founder of International Boarding and Pet Services Association. A few things before we start our webinar officially. I would like to let you know that there is a question box on the right-hand, well, on my screen, it's on the right-hand side, where you can ask questions, type in your questions. Natalie Oates, our vendor member concierge, is monitoring today for the webinar, and she will see those questions come in. And when Tracy Kaiser asks for questions, Natalie will start reading those questions off. And Natalie does very good at follow-up. So if you get an answer and you need follow-up, just go ahead and type in again. Natalie will be looking for those follow-up questions. Also, we do record our webinar, and for our members, you can find it in the member dashboard under the video library. And then also for general purposes on the IBPSA website, so it's ibpsa.com/health plan. You can see all the webinars we've done with Tracy at the Kaiser Group. And we've got two up there. This will be the third one today. We'll put that up there. So you'll be able to hear all of the webinars, listen to them, watch all the PowerPoint slides, how they've changed, and how the information is collected and how we're moving forward through that health plan. So on the member dashboard or at ibpsa.com/health plan. Oh, for the recorded videos. Okay, so I have never read Tracy's entire bio, but today I decided that you all should hear the entire bio because she's amazing what she's been able to accomplish in her career, and I think it will help you understand the range of knowledge and benefits that Tracy and her group are bringing to our industry. So Tracy is the president and CEO of the Kaiser Group. She began her professional career in the insurance industry with focus on risk management in 1984, shortly after graduating from college with a BA in finance and marketing. She built and maintained 4 successful private practice firms between 1984 and 1997, encompassing multiple state locations. In 1997, she was asked to accept an officer role for a Fortune 200 insurance company overseeing all operations in the Western United States. After leaving that post in 2008, receiving accolades as being the most accomplished in that position in the history of the company, she returned to private practice to continue to pursue her true passion for improved effectiveness in overall benefit management and strategic product development. She maintains a strong emphasis on meaningful benefit plan design and deliberate cost containment strategies with each business client the firm represents. The Kaiser Group has become a very sought-after firm to accomplish the goals necessary for today's business owners. Under Tracy's leadership, the Kaiser Group has grown into a leading benefit architectural firm with a strong national presence. This firm is made up of integrated experts who continually strive to deliver high-level benefit strategies and solutions that yield the most favorable ROIs in today's rapidly changing benefit environment. The Kaiser Group works directly with clients who have unique client needs, complex challenges, or need high-level product development support. The Kaiser Group extends that support to premier insurance professionals and industry strategists as industry partners to expand their ability to extend the most meaningful product options at the most competitive price point to their clients, creating significant market differentiation for all parties. The Kaiser Group's well-trained and experienced consultants, trainers, plan design specialists, and senior advisors work first to understand the client's goals, then strive to develop and implement a plan that responds to the ever-changing benefit and regulatory environment without compromising the solutions that are necessary to provide proper employer positioning for the future. A comprehensive approach to customization and the complete satisfaction of unique client needs are key areas of focus for the Kaiser Group through proprietary and or market-leading solutions. With over 100 plus years of combined executive experience and high-level connectivity with the most prominent domestic carriers, most well-respected reinsurers and international syndicates provides the Kaiser Group's insurance partners with the greatest opportunities to successfully satisfy their clients' benefit needs. The executive level relationships and integration deep within the integral facets of the industry, now get that word out right, allows the Kaiser Group's team to extend the proper product designs with the most current innovations while maintaining a laser-sharp focus on alignment with all current and forthcoming regulatory requirements. Tracy herself sits on several boards serving the insurance and financial industries and is a consultant for several employee benefit firms and marketing executives. The Kaiser Group's reputation as an ACA, which is Affordable Health Care Act consultant resource, is very well known with consulting integration, including as a part of overall strategy management in numerous national firms. Tracy with the Kaiser Group, welcome to, again, our third webinar.
Thank you, Carmen. That's the longest bio I've ever heard in my life. As you're reading it, I'm thinking, wow, it's really long. But thank you, everybody, for weathering that. And I can change my name to Kelly. It's not a problem, just so you know. Anyway, well, first of all, thank you, everybody. And for those of you on the call or on the webinar who we have been in touch with or have had conversations with, certainly has been a pleasure working with you through the beginning stages of this process. We're very pleased, certainly, that the IBPSA is one of the leading associations in the United States in terms of bringing the AHP or Association Health Plan structure to its membership. And as we have talked about medical plans over the last, first of all, we talked about the AHP environment and then, of course, medical plans. We're going to dig into the next segment of benefits so that you have full knowledge in this area as well. You know, we often talk about, medical insurance being the end-all, be-all, but it is the anchor. There's no question. It is the anchor of any benefit portfolio, but it's not necessarily the only thing that people are concerned about. And oftentimes it's not even the item that people are concerned about, particularly in a marketplace or in an industry where there are a lot of part-time employees or in permanent part-timers, and certainly full-timers that are secondary incomes. We find very, very often that health plans may be available through a spouse that is working, and a part-time position for one of your employees is for discretionary income, for secondary levels of benefits, and so on. It might just be certainly for standard living expenses, of course, but needless to say, we see a lot of people that are working for additional benefits and certainly taking advantage of optional benefits available through their employers where they have part-time employment. And those can be as attractive in a different way, but as attractive as the medical plans as well. Full-time employees are really focused on the medical. Part-time employees oftentimes have such a different focus. So to really be competitive in that marketplace and to be focused on being attractive to potential recruits, because we all know the market is very difficult to recruit in any industry today. But to be attractive, it's important to be able to accommodate multiple sets of needs. We all get very, very focused on, talking about the hourly wage, the vacation time, those kinds of things. Whereas, in the discussions even Carmen and I were having, oftentimes, flexibility of work schedule, extra time off, bonus incentives, and ancillary benefits discounted for them to purchase pre-tax through your system can oftentimes be a very big draw for those employees or potential employees to come on board with you and retain those positions. So today, we're going to talk about the dental division, the life, and the gap sections of a benefit portfolio. And this is where we left our last webinar, certainly was with the employee expectations of the portfolio. And then next week, we're going to certainly attack the disability, accident, catastrophic side, but we're also adding in the specific part-time benefits that are unique and specific for part-time employees, which I think will be quite attractive for everyone as well. And just as a quick, very brief review from our last webinar, because it was a couple of weeks ago, the things that really drive the four topics that we're going to be talking about today are certainly the market demand the age of your employees certainly drive the interest and the participation in the product lines, because a family has a very different need than a single person, of course, and an older person has a very different need and expectation than a person who's in their 20s in today's world. And granted, the people up to 26 years old can be on their family plans. It is surprising and refreshing, quite frankly, to see many, many, many high volumes of people in their 20s wanting to step out on their own, even though they can be on their parents' plans, oftentimes want to be on their own plan and start to pave their own way. That's obviously, a segment of that population. Then you have the other population that is still on their parents' plans as it relates to the medical plan, but they may not be on the parents' plans for other coverages. And then, of course, as we talked about, your secondary income earners oftentimes are working for benefits. So these are the things that really drive the selections. And then, of course, you're always working on price. We know that. And everybody, it always comes back to price when push comes to shove, but you have to have a good value for the price. And so in today's discussion, we're going to talk about, certainly hope to have everyone gain knowledge of these product lines, but knowledge about what you're paying for, because there are an awful lot of plans out there that will charge you whatever the amount is. And if you don't know what you're paying for, oftentimes you're not getting what you expect. Late night television is guilty of that. And certainly a lot of folks who are simply calling on someone and just selling a subject matter. And when I say a subject matter, I mean dental, for example, as a subject matter. Many folks may say things like, well, we have a dental plan. Well, what is the dental plan? I have no idea. We just have a dental plan. Well, dental plans are very, very different. So let's talk about dental first of all, because it is a very big expected component in the benefits portfolio today. First of all, you do have to think about the differences. They kind of follow, if you will, the medical side as it initially in the PPO and DHMO. PPO, we all know, is the biggest network of providers, and you have providers in the dental world as well, your dentists, of course, and so on. Your DHMO stands for nothing more than the dental HMO, and you're familiar with HMOs, as we've talked about in previous webinars for medical, which is usually a concentrated either series of facilities or concentrated geographical set of providers, service providers, and so on. Most of the time, a DHMO is not as attractive as a PPO. It certainly has many limitations associated with it. And then you have indemnity plans. Indemnity plans, it's easy to kind of get roped into an indemnity plan that you don't even know you've purchased, because you'll see those, again, late night television an awful lot. And there's one of the ads out right now that says everyone can be covered and so on. You can go to any doctor. Those are indemnity plans. And what they simply do is pay a dollar figure for services. So much for filling, so much for preventive care, so much, for certain services. And that may or may not meet the price point for a dentist. And the dentist may or may not accept that as full payment. And if they don't accept it as full payment, which is actually the norm, then you have what is called balance billing, which means the remainder of the cost of the service is billed back to you or your employees for those services. So with a PPO, we're going to go down to percentile, and then we'll talk about how to think about what's being paid. In the DHMO, for the most part, everything is paid for by the insurance coverage, but it is perceived, legitimate or not, perceived by employees as a lesser quality service. You will always have in-network and out-of-network services in a dental plan and traditional PPO dental plan. And of course, you want to stay in-network. So the key, obviously, is to have a very, very large, comprehensive network of providers, not a skinny down network or not a limited network, because then your out-of-network activity will be high, and the out-of-network payments are certainly less than in-network. So always, whether it's medical, whether it's dental, et cetera, if you have an in-network or out-of-network option, always focus on the in-network. And if you're changing dental plans, you simply ask your broker, if you're using an outside broker, not going through IBPSA, you ask them for a disruption report if you're changing carriers. And that disruption report will then take into account the carrier you're using, the new carrier that's being presented to you, and what are the differences in the doctors in that network. And for whatever reason, we're all the same. We all have our favorite dentists that we've been going to for years, and we want to maintain those dentists. So when you change dental plans, just like you change medical plans, you want to be focused on the fact that your dentist will be a participant in network for that plan. Traditionally, in your dental plans, again, aside from indemnity plans, you have a deductible, and generally those are an annual deductible. Once in a while, they are a lifetime deductible. And of course, it's all a function of price. The higher the deductible, the lower the price. The lower the deductible, the more it impacts and raises the price. So you have plans out there that are zero deductible all the way up to 100. You don't see much over $100 deductible in the marketplace at all. And they may be an aggregate of 2 or an aggregate of 3. And what that means is if you have 5 family members, the most deductibles that can be incurred in an annual space for you is 3, if it's an aggregate of 3. So if you have all 5 people in your family going to the dentist, only 3 will have a deductible tied to it. The rest will not have a deductible. So they all work that way. Copays, and we're going to talk in the next screen about how copays are set up, but copays are a very big part of dental plans. There's always an 80-20, a 90-10, a 70-30 kind of component in the dental plan. Annual maximums range from $1,000 at the low side all the way up to $2,000 at the high side, but you can certainly establish plans also that have unlimited maximums. Now, granted, there's, unlike healthcare, you're not going to have millions of dollars in dental care. So even an unlimited maximum may be several $1,000s that are incurred expenses, but nevertheless, you have that range all the way down from $1,000 a year up to unlimited. And what happens with many plans is that if you don't use your full maximum benefit, again, if you have a designated dollar figure, then whatever you have left over, usually a multiple is applied to it, and it can be rolled over into the next year. That is important for planning. If you have $1,000 maximum on your plan, for example, and many plans are set up that way, or $1,500, that's not going to take care of, a series of crowns, implants, et cetera. And so you may think, gosh, in the future, I want to do X. So since I have my plan this year, and I'm going for traditional fillings or cleanings, et cetera, I may not use all of my maximum benefit. So I'll think about rolling that into the next year if that's available to me, and then adding to it the following year, et cetera, if it's available to me, to end up with a little bit higher max in 2 or 3 year periods of time, so it can pay more of my large expenses. Many dental expenses, unless they are urgent situations, can be pre-planned. And so dental insurance is about pre-planning that as well. Not all plans have carryover, and if they don't, that's not a bad thing. It is a reflection of price as well. If you have carryover, it's always reflected in the price. Percentile. When you deal with an indemnity plan, there's no percentile of a cost. It's just a dollar figure. When you deal with a DHMO, it's not really a percentile because you're working within that small, limited network. When you're dealing with a PPO, it is important that you have a very high percentile of claim payment. And you want to stay very, very focused on only carriers that pay at the 90th percentile and above. And what that means is, of the expenses, if it's a $1,000 expense, you would expect that insurance plan is going to pay at least $900. And generally speaking, the great majority of all the expenses are taken care of by the insurance plan. So if you have a plan, and I won't use names, of course, but there are some plans that really promo, we have the best doctors. Well, they have the best doctors, but they don't pay a very high percentile, so you get balance billed a huge dollar figure as well. The other networks all have the same doctors and more, and they pay at the 90th percentile, and so therefore your likelihood of getting balance billed is minimal because that dentist or orthodontist, et cetera, may accept that payment as 100%. They certainly do at 90%, and so your balance bill is very, very, very small. So when you look at how are copays set up for dental plans, first of all, there's always level 1, 2, and level 3 expenses. And you'll see the insurance agents talk like this. Well, we're going to do a 150 or 180-50 plan. And you're like, I don't even know what that means. Well, what it means is level 1 expenses are paid at 100%. And typically speaking, all level 1 expenses are paid at 100%. Level 1 expenses are focused on preventive services like routine exams, cleanings, fluoride treatments, x-rays, which are your standard x-rays, not because you have a cavity and need an x-ray, but because they're doing x-rays as a standard part of benchmarking. Second opinion consultations are all considered preventive services as well. Level 2 expenses are where you have that 100 and then you either have 190 or 180 or 150. And they usually range right in the 90, 80, or 50. And what that means is your basic procedures, which are things like fillings, the stainless steel crowns, your simple oral surgeries, emergency exams, complex oral surgeries, the basic procedures are paid at either 90%, 80%, or 50%. And again, it's a reflection of cost. If you have a plan that's 190 and then go on down from there, it's going to be more expensive than a plan that pays 100% and then 50%. And then, of course, you have level 3 expenses. Level 3 expenses are your major things: crowns, bridges, dentures, endodontics, general anesthesia. And those are paid starting at 50%, sometimes at 30%. Sometimes they're voided altogether, again, to get a very inexpensive plan. And if you're a group, let's say, for example, and I'm just ballparking this, it's not a piece of advice one way or the other, is let's say you have a group of very young people. Generally speaking, you're not concerned about dentures and bridges and crowns. And so level 3 expenses are not as relevant for your type of a group. And so you can reduce costs by simply getting rid of level 3 expenses and putting your money into the level 1 and level 2 expenses. If you're a normal average group with varieties of ages, then of course you need all services because people have all kinds of needs. And so when you look at a plan and it says it's a 190-50 plan, that means 100% level 1, 90% level 2, 50% level 3 expenses are paid by the insurance, and the remainder, of course, is paid by the employee or the member as well. So that's the dental 101, if you will. Some of you may know this information. Some of you may not have known this information. And what's always unfortunate is when people have a dental plan and they have a subject matter that they don't have knowledge of their actual plan. And if you don't know how it works, you can't manage it properly and you can't get the most from it. So the important thing is to understand what you're actually spending your money on, understand what you're representing to your employees, and let someone help you, or at least understand your plan so you can manage it and get the most from it. I'm a firm believer if you're spending money on an insurance plan, make sure you're getting your money's worth from that insurance plan, particularly in these areas. Now, dental insurance, we're going to talk about contributions from employers, employees as we get a little further in the program here today. But dental insurance can be employer paid, can be partially employer paid. It can be 100% employee paid and offered simply as a voluntary benefit. And all three of those are handled with equal satisfaction from employees based upon the structure there at your company. Second part of what is a normal package for benefits in today's world is vision. Dental without vision is kind of absent something. And so we all need, dental and vision. And even if we're not wearing glasses today, we're getting our eyes checked. We may wear contacts. We may have a medical situation that requires something down the road. But typically speaking, if you have family members, of course, you're getting eye exams every year. Of course, you still have in-network and out-of-network facilities. And you're going to see charges or benefits in your vision plans that are based on wholesale pricing in some instances versus retail pricing. That's an advantage for you as well. Frequency of care is what you have to be concerned about, because you don't want something that only lets you go get an exam every 2 years when you're required to get an exam every year, either for school or for a job or what have you. Waiting periods, there should be no waiting periods in a vision plan. And generally speaking, you will eliminate waiting periods in your dental plan. The only time you get into waiting periods in a dental plan is for major services. And those are in unique scenarios where you have not had a prior dental plan, you may be a small employer, et cetera. And then again, it's a very limited window of waiting periods. Full and part-time employees are eligible for the vision plan through the IBPSA, and certainly are eligible for the dental plan through the IBPSA as well. And those will be the same benefits as your full-time folks. You should always have the next three components in every vision plan. Don't ever have a vision plan without exams, lenses, and contacts. And of course, you should have frames in there too. I'm not sure why that skipped out of there, but frames, add that in the fourth component. And then, of course, your provider profiles are based upon the carrier. Some carriers will promote They have the biggest independent optometrist networks. And that's great, but not everybody has independent optometrists near them. They may have the Lens Crafters or the Sears Optical or the Pearl Vision or the other host of all the other new retail stores out there, the Walmarts, the Targets, the Costcos, and so on. So others will promote, we have the biggest retail network, and then others, which is what you want, have the best of both. You have the retail network and you have the independent optometrist. So whether you're in a rural or a metropolitan area, your needs are satisfied for your employees and for yourself. So you have to be very, very careful about what the focus of a vision provider or vision carrier is. And they are very distinctly very different. So, and be surprised, many vision carriers today actually own and have all kinds of agreements with the eyeglass manufacturers. Some of them actually own the eyeglass manufacturers, so they can discount the pricing to get you very good quality glasses very heavily in terms of discounts. So kind of bear that in mind as well. Here's the way the structures are set up for vision care. First of all, your exams, you generally want a 10, 15, or 0 copay. Anybody who goes to an eye doctor or Lens Crafters or anything knows that your cost is going to be anywhere from $70 to $120, depending upon where you live and where you go. And so you're going to just simply walk in the door and only pay $10 out of pocket for an eye exam, far and away returns the premium that you have paid for a vision plan back to you, because you're not going to even pay that difference in the vision cost for that year. So, 0 copay, $10 copay, $15 copay, and they even can get up to $25 copays to reduce costs. But the cost of vision care for all the members here through IBPSA is incredibly low. So I wouldn't worry about trying to discount too much money by going to a higher copay. Your costs are going to be extremely minimal. We'll talk about costs today. With your frames, you're always going to have an allowance, and it's always going to be based on allowance versus copay. The allowance is either going to be a retail or wholesale allowance, and that a retail is a given. You walk in the door, you see what the price is, et cetera. A wholesale price is going to be what is that wholesale price, and your allowance may show, for example, $60 wholesale versus $160 retail. Well, those may be related to each other or equivalent, but generally about a $50 wholesale allowance is equivalent to about a $220 retail price point for in the vision care industry. And so you just have to think about it differently, and then they apply the wholesale price point. So for those vision carriers who may own certain facilities, you have the advantage of that wholesale price point. Now, you can always buy up. It doesn't mean you have to limit what you do, but if you are a person who wants those, Vogue, brand glasses, or those Tiffany brand glasses that are far and above a $200 price point or a $160 price point, then of course you can always buy up for the difference, and there's still a discount on those price points through your vision plan. Typically, those discounts are about 20%. Lenses, this is an important point, because anybody who's gone to the eye doctor knows you walk in thinking you're going to pay a couple $100, and you walk out paying $700 for a pair of glasses. You don't even know how it happened. Well, it happens a lot with lenses. So your copays on your lenses are very critical. With your single vision, your bifocal, and your trifocal, which are your standard, of course, lenses, your copays all apply, and you can choose. Again, it's $0, $10, $15, $25 copay are pretty standard for your lenses. If you buy up into, let's say, progressive lenses, high-level tinting or the fading kind of lenses, or some kind of coatings that are non-glare that are the high-level ones, generally, if you have a $15 copay, you'll pay $15 for that next step up, $15 again for that next step up besides that, $15 again if you step up to yet another service. And so it compounds. That's typically the way they're built. They don't all have to be built that way, but that's very, very typical. And so, so you can manage certainly that cost, and you should use your vision plan to help buy down the expenses on those other costs, because anybody who wears progressives on this webinar knows that those can be pretty pricey. And so just adding another $15 or $25 for those is quite less expensive. And then, of course, contact lenses. For those who are wearing contacts, again, there's allowance structure anywhere from $100 to $200 typically on an annual basis. And of course, if contact lenses are medically necessary, then there's no limit to the allowance. You certainly have them within the plan in most all vision plans at no limitation for the allowance. Also recognize that if there's an injury that requires dental work or an injury or illness that requires vision, services as well, it really doesn't apply to your dental or vision plan. It applies back to your medical plan. So, vision care, dental care are for standard vision and dental services, not for something that has occurred like a car accident that has, knocked several teeth out, et cetera. That's where you start working with your vision plan, or your medical plan, pardon me. So as we move past those two services, and again, a lot of people say, I have a vision plan, but I don't know what it is, and they just get used to walking in and giving the card without knowing what it should pay. You need to know what your plan pays, so when you're there, you're making conscious decisions about, and your employees are making conscious decisions about how they're spending their money. Always know that the cards are going electronically these days. The old days where we all had cards, and to some degree, some carriers are still doing some cards, but you never really need a card. When you go to a dental or vision care provider anyway, they can pull you up with your birth date and social security number and name, and you're in a direct, database, electronic database that they all access anyway. They can tell you what your insurance is, and they can tell you what your benefits are when you walk in the door, whether or not you ever have a card. But cards are going electronic, so get ready for mobile apps, electronic cards that you shake the app when you're there at the dentist or the optometrist, and your card just pops right on up. So, technology is a great thing as it works for us, of course. Life insurance is also kind of a given, in that package. Your medical, dental, vision, life are really the standards that people expect. And as an employer, you have multiple options. You certainly can provide what is called basic term life that's paid by the employer. And if it's something you want to provide universally for your employees, then it is something that has to be 100% paid by the employer. That is not an option to be voluntary for the employee, like dental and vision. It's always based on a term life scenario. I would always recommend having AD&D added to it. It only costs about 4 cents to add AD&D, and what it does is double the benefit if they are injured or if they pass away based upon an injury. And so if someone has, let's say, a $10,000 life insurance plan that you as an employer provide, first of all, that is interestingly a very big perk for the general potential recruits out there and for your employees. You may not think of it that way because you're business owners, of course, but for an employee who has no life insurance, it's always surprising how important that $10,000 is, because it is enough money to bury the person if they do pass away. And without a life insurance plan, you'd be shocked at how many employees come back to the employer and actually expect the employer to pay for funeral services. And so as an employer, you want to keep yourself out of that role, because once you do it, you've established a pattern or a point of activity that you don't want to continue. And so you really shouldn't do it, because it becomes very discriminatory very quickly. So as an employer, if you want that off your shoulders and you want to have a very low paid, high value benefit, you can incorporate a $10,000, $15,000, or $20,000 life insurance plan. Some incorporate $25,000. But at a $10,000 life insurance plan, again, for a general group, it's going to cost you less than $5 a month as a generalization. And so it's wise to do that. Guarantee issue always, and it's for the employee only. You're never providing basic term life insurance for family members. It's always employee only, and it's 100% employer contribution, as we spoke about. And when a person leaves your employment, they do lose that life insurance. That is an employer-employee-based plan. It is not a plan that they can convert to an at-home payment situation. All employer-paid basic term life insurance is built the same way. So you do have some of that stickiness, if you will, that we've talked about in the past with those employees to keep them with you, because they can only get certain benefits if they're with you. And I will tell you the benefits with vision and dental that we're going to talk about in a few minutes through your group here with IBPSA. They're not going to be able to get that in the open market either. So when you move over though to employee paid life insurance, and life insurance then goes into an employee voluntary paid option. The most common is a term plan, guarantee issue, again, up to a certain level. Typically for a small group, it's $50,000. For a larger group, it's $100,000 with no medical questions. And typically, you can provide evidence of insurability, which means medical underwriting questionnaire, to boost those levels up as an employee, to boost those levels up to 200, 250,000, somewhere around there, and spouse coverage and child coverage as well available at the employee cost. All of those plans are convertible, which means they can convert it to usually a whole life plan at home, maintain paying for it at home if they ever leave your employment. Most people in today's world do not have life insurance on their own, and they do rely on their employer to provide either a source of life insurance or to provide a life insurance plan for them. As an additional statistic, vision and dental plans, 98% of all vision and dental plans in the United States are standalone plans. They are not a part of medical plans. And those of you who have had a medical plan where you have the ACA component that's required to have the medical or the dental and vision in it, those are not dental and vision plans. Those are just some very small preventive service type benefits, not to be confused with a dental plan at all. Employee paid additional options, and this is if you get a little bit more advanced, if you will, in the life insurance world, is you certainly can move to whole life plans. You can move then to universal life plans as well. Those generally are a very small dollar figure that's guarantee issue, and then of course you can medically underwrite to move into a larger plan. Universal life is typically medically underwritten, but it is a savings component that they can keep for the duration of their lives, as they move away from your employment as well. Whole life is also transferable to an at-home situation. Term life we talked about. Medical gap is the area where it's a complete unknown for most people. Incredibly popular to help keep costs down in your medical plan. I'm kind of moving back to medical insurance here for just a moment because I think it's an important discussion point just from a strategic thinking standpoint. You can incorporate a gap plan, that not to be confused with things you see out there and are presented with, like hospital indemnity plans, limited medical plans, those kinds of things. Those are different plans. Medical gap is designed to work truly in conjunction with the deductible associated with your medical. So that years and years and years ago, we used to have things called first dollar coverage. You didn't have deductibles. This goes back a lot of years. And so when you went to the doctor, you didn't have to worry about a deductible when you went to the hospital. Today's world, the deductibles range from $1,000 on the low end, way up to $6,350 on the high end, and actually I think they're stepping just a little bit higher than that now, but everything in between. Anything over a $5,000 deductible is considered high deductible, $5,000 and above. Anything less than that is pretty standard in the marketplace, and so you see $2,500, $1,500s, and $3,500s as very standard. $5,000 deductibles as trying to keep that cost down. And the deductible component of your insurance plan, your medical insurance plan, is really driven in the service areas of hospitalization and services associated with the hospital, as well as some diagnostic areas of your plan. Most of the day-to-day things that happen, going to the doctor, going to the specialist, going to the urgent care, picking up your prescriptions, are all dealt with by a small copay. But the deductible, where you have to be concerned about that, is if something serious is happening, you have a deductible that you're responsible for. And typically, it's either deductible pays first, then you go into coinsurance up to a max, or the deductible and the coinsurance work jointly to get you to the maximum out-of-pocket that you have to pay. And in today's world, of course, that's right around $7,000. Used to be unlimited. So medical gap is a very, very, very important tool to help keep costs down when, as an employer, you're focused on cost and you can only put in a high deductible plan, a $5,000 deductible, let's say, for example. And everybody kind of, their eyes get big and it's like, oh my gosh, I can't afford $5,000 if something happens. Well, most of the time, statistically speaking, in the United States, we use about $1,800 of our deductible on an annual basis. That's a broad-based statistic, not to be confused with people who have serious issues that happen, and others that really don't use it very much at all, but just as a general statistic. So we know that that range is always going to be, people using it under that $2,000 mark as a standard. Again, you have to make your own decisions. But if I have a $5,000 deductible for my employees, and I put in, let's say, for example, a $2,500 gap plan. First of all, the effect of that gap plan means that in certain areas, which you see in the inpatient and outpatient services here, I now have provided to my employee first dollar coverage because the gap pays first as a part of the deductible before the employee pays any part of their deductible for the areas that it covers. And so if I go into the hospital, for example, and I have a $2,500 gap plan, under a traditional deductible, $5,000 deductible, I would be responsible for that first $5,000. If I have a gap plan with my medical plan, my gap plan takes care of the first $2,500. After that, I take care of the next $2,500, and then the insurance takes care of. So now my out-of-pocket is $2,500 versus $5,000 using that example. And so is a medical gap plan as expensive as having a $2,500 deductible plan? Not at all. Medical gap plans are very, very cost efficient. And if you have a deductible plan, high deductible plan with a medical gap plan on it, chances are that rate's going to be significantly lower than simply putting in a $2,500 gap deductible plan, which the end result is a better result anyway, because again, I know this is confusing, but because having a $5,000 gap, $5,000 deductible, $2,500 gap plan gives you first dollar coverage for the first $2,500. A typical $2,500 deductible plan gives you no first dollar coverage. You just pay the first $2,500. So it's a better option to incorporate medical gap plus a high deductible plan than to try and put in a lower deductible plan as a generalization. And again, you have to look at it always, but from a strategic thinking standpoint, as a business owner, you're trying to figure out, how do I spend my money most wisely? How do I get the best bang for my buck with my employees? And how do I get the best response from the employees so the employees are actually happy with the insurance plan? That's critically important. And so when we look at the word embedded, oftentimes a medical plan is introduced to the employee base, and let's call it, using that example, that $5,000 deductible, but it has a $2,500 or $3,500 gap plan on the front end, so that the impact is certainly after the fact, and the total price is the gap plus the medical plan, far less than, again, having a lower deductible for the medical plan. Or oftentimes an employer will say, look, here's the medical plan, here's the contribution, et cetera, but I'm going to provide, or I'm going to cost share the medical gap plan for those who want to add it, or as a standard, just pay for it for everyone. At the lowest level, you can buy up as an employee. The lowest level might be a $500 gap plan that you put in, which is pennies on the dollar. Employee paid, of course, can always be a voluntary option. And for those folks who think they're going to use their medical plan or have a reason to believe because they have medical circumstances that they're going to use their medical plan, are incredibly wise to have a gap plan there. Or if someone simply says, I can't afford, the out-of-pocket if something does happen, it's always easier to pay small dollar figures per month and have that coverage if something does happen. But that's the medical plan impact. And I know it's a confusing component, and you might be wrestling with now, how does that work again? But just kind of think back through it. Medical gap plans provide first dollar coverage and eat away at that first part of the deductible. But, what are the areas that we're most concerned about? Hospital, surgical, physician in the hospital, and then, of course, outpatient, surgical, diagnostic, hospital, and physician. The way that gap plans work typically is this. If I have a $2,500 gap plan, what that means is inpatient, the first $2,500 associated with my deductible is going to be paid for these services. Outpatient, half of that, so $1,250 will be paid again in that annual period of time. So really a $2,500 gap plan is a $3,750 benefit. That's a big benefit for the low cost. And again, every group is quoted differently based upon the population and so on. But I wanted to bring that up because oftentimes we just look at medical as medical standalone and we really can't do anything about it. There's a lot that can be done about it if you're willing to work from a strategic standpoint. We talked about, and these are some questions that are coming up from the benefits discussions that we have been having so far. And I want to thank everyone for your patience as we're getting to you to incorporate those benefit discussions and review your benefits, review your information, see where we're able to go from a benefit standpoint to serve your needs. The pre-tax advantages are very important. As an employer, you're very focused on, how much is it going to cost me, of course, as well as how much is it going to cost the employee. But let's also remember that as an employer, you have the opportunity of incorporating a pre-tax Section 125 of the IRS code. It's actually Section 106 of 125, which is the premium-only section that allows you as an employer to redirect your insurance premiums, certain insurance premiums, from an after-tax position to a pre-tax position in your payroll system, therefore reducing payroll taxes for the employee and payroll taxes for the employer, and in some cases reducing your workers' comp liability just because it reduces payroll. But again, it could be minuscule, so it may not make a difference there. So what coverages are available to be pushed pre-tax? And anybody who's using any payroll system, ADP, Quicken, anything else that you're using, it's usually just a click of a different button, and it will automatically redirect your insurance premiums pre-tax. Advantage is you reduce your tax liability. Advantage for the employee is they reduce theirs. And health insurance that the employee is paying for, and it's all about what the employee is paying for. Health insurance, dental insurance, vision insurance, gap insurance, any accident type coverages. Life insurance and disability insurance is not eligible pre-tax in mass. There are some exclusions, limitations in there, and some caveats, which we can talk about independently, but as a general rule, those should not be put pre-tax. And the question's been coming up quite a bit about employer contribution. What do I have to do? What do I need to do? What are my options? Will I get in trouble if I change this, et cetera? Well, typically it's percent of the total, of course, and for the employee only. There's been a lot of confusion about, do I have to pay for employee dependents and spouses if I contribute for the coverage? Not at all. The general rule is that you pay for your employee as a portion of the total. And if you have multiple plans and you want to be consistent with ACA, even though you may not be required to because you're not large enough yet, you can, and you can still do this on your own, ACA or not. ACA stands for Obamacare, but ACA or not, you can contribute a portion of the smallest plan or the least expensive plan, and those who then purchase higher plans can buy up at their discretion. So you don't have to pay for 50% of everything. You can pay for 50% of all plans if you have enough employees to have multiple plans, or you can simply pay 50% of the lowest cost plan. So typically 50% is the contribution by the employer. Typically carriers expect that, and it's all about participation. We find that when the contribution model is less than 50% by an employer, it's much more difficult to get participation from the employees for a lot of reasons. They just have a higher, dollar figure. They may have a little bit of angst about the employer not paying for half, et cetera. And so if the employees don't participate, then it doesn't become a viable plan, of course. And so it's important they participate. So we really do recommend at 50%. Certainly there are a lot of employers that pay more than that, 70%, even 80%. And some employers pay 100% for tenure, performance, and so on. And you can do that. So it is your discretion, but you are not required to pay for family members. You can, but it is not the norm. You can also incorporate a defined contribution, and you just want to make sure that that defined contribution or a static dollar figure, call it $100 a paycheck or something, a static dollar figure needs to equate to a reasonable contribution percentage, and to make sure that, again, it's not falling into a category of only being about 25% and so on. So again, a static dollar figure oftentimes is easier for an employer to plan from a budgetary standpoint if they're planning for growth and so on, because a static dollar figure may be what you contribute regardless of the age of the individual. And so if you have a percentage of the total, older individuals may cost more than younger individuals, and it's much more difficult to plan. And you also have the opportunity, and I spoke just a moment ago about that as it relates to tenure-based incentives. That's been a question that's come up quite a bit. If my employee stays with me, or employees stay with me 2 years, 3 years, et cetera, can I increase my contribution based upon their tenure? Absolutely, as long as you do it for everyone who fits that same criteria. We always recommend, and I know through your business planning there with IBPSA, I'm sure you're getting introduced to the right HR components, employee handbooks being one of those. if you have an employee handbook or something of some semblance that outlines your structure and your guidelines and the expectations and so on, and your rules and regulations for the business, what have you. We would recommend getting it to an employee handbook, but in absence of that, make sure it's distributed to everyone. But in your employer handbook, it should outline, those kinds of things. If you have a tenure-based incentive or some other kind of incentive that you want to incorporate for anything, but because we're talking about benefits, in this case for benefits, then it should be noted and it should be applied to every single individual. The last thing you want to do is have discretionary or make discretionary decisions for your employees based upon who might be a friend, who might have just been there longer, who might be doing a better job, whatever the situation is. It becomes very discretionary if it's not written down. And so the objective today was to focus on these ancillary components that a lot of people kind of blow off as, well, I got to focus on medical, and then the rest of it's just really kind of there. Not so much. The rest of it can create a lot of bang for the buck, if you will, and you'd be surprised how many people really do put a lot of value on their dental and their vision plans. And why? Because they use them all the time. And when a person uses their benefits all the time, they start to see value, because usage creates value. Value creates happiness, of course, in the benefits as well. And so from a medical standpoint, especially if you're dealing with younger people, they don't think they're ever going to be sick, and they just see it as, gosh, why don't you just give me the money? I don't care about the medical insurance. And you hear that oftentimes from younger people or people that may not have families. And so obviously that's not an option. But you don't, unfortunately, oftentimes you just don't see as much value in the medical plan because people don't use it every day. They go to the dentist all the time, they go to the eye care doctor all the time, and they see their insurance working. So you get a lot of bang for the buck. Cost for the dental and vision and the ancillary components that we've talked about already are already established and in finalization for launch on January 1 for the IBPSA. And if you're thinking about budgeting, what does a range cost? Well, in the vision area, range of cost is typically around $4.50 a month to $7.50 a month, depending upon the extensive benefits you want in the vision plan. From a dental plan, how much does it cost? Well, it costs anywhere from about $16 a month to about $30 a month, depending upon the components you want in the dental plan. And those are employee figures, of course. And everything then it becomes a function after that for family members. But when you're thinking about budgeting, all of that's very affordable for any of us as consumers or employees anywhere. And it's also, quite frankly, affordable at the employer level if you're wanting to contribute to those plans at your option. You do not have to. And then, of course, life insurance, we spoke about it. For a small life plan for everybody across the board, probably looking at about $5 or a little bit less. And that, again, becomes very, very affordable. And for life insurance voluntary for the employees, of course, it's a reflection of their age. Everything is age banded at that point, as is GAAP for the employee. Or if the employer wants to incorporate it, embed it into a medical plan, then, of course, we would develop a composite rate for that specific plan so that it's not age banded. And then there's a rate that everybody has the exact same rate added to their medical plan. So again, based upon the medical plans you choose when we get down that path, will drive the cost of GAAP coverage. So I wanted to get this in your hands because this is a part of every benefit discussion when we're going over the medical plans, and it needs to be because medical without dental, vision, life is really absent of these coverages. At the same time, medical with just vision, dental thrown out there and not really knowing what it is a waste of money because your people aren't using it the way they should use it. And we want them to keep their teeth in good shape, keep their vision in good shape, keep their medical health in good shape as well. So wellness and the use of preventive services in all of those products are very, very, very important. So at this point, I want to close the educational component of the webinar for these products and know that next week we're going to be dealing with disability, certainly the catastrophic side of things, the critical illness side of things, and the very specific part-time employee benefit portfolio that's available for your part-timers as well. And so, so with that, I'll open it for questions if that's available, Carmen. And again, I appreciate everyone's attention. I know insurance is not the most exciting topic, but we consider it rather sporting, so we think it's very exciting. But it is exciting to be able to bring you good services, good benefits for the right dollar figure. So with that, Carmen, I'll turn it back to you if I could, or Natalie.
Thanks, Tracy. Natalie, it looks like we just had the one question that came through. I don't see any more, unless you have a couple that I don't see. So the one question that came through, that's it? Okay. So the one question that did come through is that people assumed that they would be hearing how much the health care plan was going to cost today. So there's no way we can do that for each of you. It has too many factors that decide what your health plan cost is going to be. So Tracy, can you address that just for a moment, all the different factors that come into play for that quote to happen?
Oh, absolutely. Absolutely. And again, I know that's a natural inclination for someone to say, gosh, I need to know what my price points are. That's natural for anyone to be coming to a webinar and thinking. We are well in the throes of the data analysis, benefit discussions, modeling the plans themselves. And we expect that by midweek next week, you'll see price points and plan designs. As a matter of fact, some of your employers are already in line to have those in their hands by next week. Those that were most urgent, that had these really urgent deadlines. And if you have not been in that schedule yet or have not necessarily completed that call yet, you will be over the next few days. And I think those calls are into next Tuesday as well. But by the midweek next week, you'll be seeing ranges of prices and so on. You know, I understand that there's a couple of or several components that actually make a difference. One is the state you live in, of course, drives certain requirements from a medical standpoint. And because this is a national association, there are components that have to be adjusted for states. And so depending upon where the state is, where you are, obviously it adjusts the medical plan availability. And then, of course, you have your population. Of course, you are a part of a total risk group. So you have the best of blending, if you will, the advantages of being part of large numbers, even though you may be a small number as well. Obviously, with AHP as being a federal introduced advantage from a benefit standpoint for members of an association, there still are state Department of Insurance regulations that have to be complied with. So even though we just talked about the states you live in drive the insurance components, they also drive a lot of other availability issues as well. So we have to work within each of those capacities. And if you are in a very unique state, for example, that is the governor has said, we will not agree with AHP plans and you must go through our state exchange and we're not going to support anything else, then we'll be working with you individually in that capacity. And there are a couple of those states out there, but don't be concerned because it just is what it is. And certainly when the federal government comes out with anything that's new, there's always going to be a little bit of backlash. So there's a few states out there that are opposing availability. So we have to be aware of that. But everything is based on risk. This is, medical insurance is not a commodity product. It's not when you go to the grocery store and say, here's what the price is for everybody. It is very much based upon what the population of the membership looks like, ages, medical situations, dependence, geography, medical care costs in those marketplaces, et cetera. And all of those factors come into play. So quite frankly, since we've been working on this plan, actually the timeline has been shortened dramatically from a typical timeline. Typically, you might start being introduced to a data requirement, and you might have something 3 or 4 months later. From an underwriting standpoint, that process has been pushed very aggressively to meet the January 1 deadlines and the launch for the IBPSA, and certainly to fit in within the AHP timing requirements, because IBPSA is permitted to launch January 1 based upon the requirements, the federal requirements for AHPs, Association Health Plans. And so there's no question that there are going to be advantages for you to be on the IBPSA health plan. There's no question you will have additional services and additional benefits within your health plan as well. If we have some unique, crazy scenarios that require you to stay in what you have or require you to go to the exchange for some scenario, we'll be very forthcoming in recommending and helping you do that as well. But for the most part, everyone will be eligible in the medical plan. But there's a lot more that goes into it than just, hey, what's our price? And even if we didn't get our data in, do we have a price yet? If you didn't get your data in, you probably won't have a price at all yet. We still need to have a conversation and help guide you and know what your state is and all that sort of thing. So bear with over the next week, and we have some deadlines that are December 5th deadlines based upon the exchanges in the states. We're very well aware of those as well, and we're hitting the December 4th, December 3rd windows for completion. And that's a tight deadline, there's no question, but nevertheless, it is meeting that deadline. So don't be in too much of a panic. I will say that if you have not been communicated with yet, or just feel like you need additional assistance, like right now, or you haven't supplied anything yet, you have the email right here at the bottom of the screen. Please send your information there, because that is monitored constantly, and we want to make sure everything stays in one place so it doesn't get lost through sending it to multiple people. And that helps everybody stay on task. And so we have a very, very, very full schedule of benefit discussions and plan build activity that is going on. And so those deliverables, Carmen, are expected to be next week. And so we should be able to, again, individually, as we're having these discussions, we're also going back and doing that. But in a larger scale, we should be able to put that into the webinar as well.
Terrific. So folks, on the chat, you should have a chat box. You can see where I've put in the link for the ibpsa.com/health plan. Follow that link. About middle of the screen, maybe toward the bottom, it'll say ready to request more information now. It asks for your name and your email. As soon as you do that and hit submit, the form is delivered to your email box. Download that form, complete the form, and then immediately send it over to ibpsa@thekaisergroup.com, which is on your screen. That takes it right to the Kaiser Group. Some of you have reached out to IBPSA and said, I've done the form, I haven't heard back. I have copied you and said, I've reached out to the Kaiser Group to say, hey, this individual has sent in their form and they haven't heard back. Please let me know that you received the form. That's all I'm doing. And then I'm letting those people know that I have reached out to the Kaiser Group. But you don't have to come through me to get that. You can just ask the question directly at ibpsa@thekaisergroup.com. I have to tell you, this team has worked their tail ends off to deliver quickly a plan in the amount of time. When I went to her and Tracy and I talked, and I said, can we do January 1st? She's like, we can do it. I was like, okay. So Tracy just told me this morning that her entire team is working 2 shifts, and they'll be doing that through the end of the year to deliver not only to their current customers that they have, but with the additional work of IBPSA. So they're working really, really hard. So Tracy, if they don't hear from you like the end of next week, if they don't hear from the Kaiser Group by the end of next week, they should be reaching back out, I would think, and say, I still haven't heard anything. They should have at least one contact by the end of next week,
Actually,
I would think. Would that be correct?
If you have not heard anything, if you have not heard anything by Thursday afternoon of this week, please reach out to us, because our objective is to either have everyone in the schedule or addressed or off the schedule or completed. And we certainly have scheduled discussions through next week, but we want to make sure that everyone has been communicated with and is in the schedule by the end of the day on Thursday of this week.
Fantastic. Okay, folks. Well, again, you will find this webinar for review at the ibpsa.com/health plan. You can see the other previous 2 webinars. I know that it seems arduous, if I can use that word, because it is a lot of information about insurance. And I appreciate the Kaiser Group and what they've done on providing education before you fill out the form, and then also the education that you get once they reach out to you and the form's completed and they start talking to you directly about your business needs and insurance needs, and how they really work to make sure you understand exactly what's available and what you really want, but maybe you hadn't considered before. So Tracy and her group have just been really, really fantastic at educating along the whole way. And so I hope that you take the time, even if you have to take it in 10-minute bits, to listen to the webinars and make sure you really understand what Tracy's trying to educate you on as it comes to insurance in general, and it might give you some ideas of what you can use in your facility. Tracy, thank you again, and we look forward to having you back next week.
Thank you. It's our pleasure. Thank you, everyone.
Y'all have a great week. We'll see you next Wednesday. Bye-bye.